Welcome everyone, Jane McKay, and here I am today, and I'm going to be talking about dysautonomia, a common thread between long COVID, ME/CFS, and fibromyalgia. So the dysregulation of the autonomic nervous system can lead to orthostatic intolerance, which has its own group of illness, orthostatic hypotension, and initial orthostatic hypertension that we won't talk about today, but we're going to focus a bit more on POTS. So thanks for coming, and chat questions in the chat, please. So again, dysautonomia, quick overview, orthostatic intolerance, the symptoms, POTS and diagnoses. Then we'll sort of stream into non-pharmacologic support, pharmacologic support, and how you might track your illness symptoms. So, oh, sorry about that, went too fast. A dysautonomia, so a disorder of the autonomic nervous system, or I often say the automatic nervous system that controls our inner organs. Cardiovascular is today's focus, but it also affects the gastrointestinal system, sweating system, thermoregulatory, your eyes, and genitourinary. So how common is it? So in ME/CFS, very common, 50 to 80%. When you look further down line, orthostatic has got a wide range, 60 to 90%, and POTS 20 to 50%, so quite prevalent. Dysautonomia and long COVID, 50 to 70%. POTS sits about 30%, and then the related disorders of standing symptoms are intolerance, orthostatic intolerance, it's 70%, and then only about under 18, roughly 18% have hypotension. That's one of the differences with POTS. Now, dysautonomia does exist in fibromyalgia. So the best current evidence that I could find is that 50 to 80% of individuals suffering from dysautonomia have orthostatic intolerance, up to 70%, wide range. But I think the common thread here is all of these complex chronic disorders can have alterations in the nervous system that controls many functions in our body. So what is orthostatic intolerance? It is an umbrella term for a group of related conditions causing symptoms when you stand that improve when you lie down. So there's one initial hypotension, so your blood pressure drops briefly on standing, recovers rapidly. Orthostatic hypotension is when there's a significant drop in pressure that will last for a longer period of time. And then there's POTS, postural orthostatic tachycardia syndrome. Again, syndrome diagnoses, excessive increase in heart rate within 10 minutes of standing, without a significant drop in blood pressure. So again, this is just a repeat, really. Orthostatic intolerance reflects the inability of your autonomic nervous system and cardiovascular system to adequately compensate for gravity-related blood pooling when upright. So orthostatic intolerance causes reproducible worsening fatigue, cognitive dysfunction, dizziness, palpitations, weakness, and other symptoms during upright posture, which improve when you lie down. Regardless, this is the important part, regardless of whether you meet a formal diagnosis of POTS. So this is one paper that I really like to highlight. One group, the American Autonomic Society, and other experts recognize orthostatic intolerance as a common manifestation of both ME/CFS and long COVID, regardless of whether formal POTS diagnosis is made. So to me, this is a real big win that we're getting this recognition. So I want to go through system by system because many, when I'm interviewing, don't realize that orthostatic intolerance can cause a wide array of symptoms. So in the cardiovascular, you're going to get palpitations, heart rate, rapid, lightheadedness, sometimes pre-syncope, like the feeling you're going to faint, and then syncope, you do faint. less common though. So what happens cognitively? Again, many call it brain fog, but really difficulty concentration, impaired attention, word finding, and slow processing speed. The neurologic symptoms you'll feel dizziness, visual blurring, tunnel vision, head pressure, headache, and then generally fatigue, worsening with upright exercise intolerance, tremulousness, I hear a lot, weakness, nausea, shortness of breath, heat intolerance. So the symptoms of orthostatic intolerance are actually quite broad, and I've mentioned it mainly to bring more attention to standing upright can cause more than your heart rate changes. So let's dive into POTS. It's the most common orthostatic intolerance, also the most common uh, dysautonomia by far. So position is upright. It's orthostatic, means just changes with position, tachycardia or heart rate goes up. And it's a syndrome, which we're going to spend a bit more time on in the next while. So here's how you can make a diagnosis. We can use a passive standing test, sorry, which is actually called the Nassau Lean test. This is an example of a lot of individuals helping this person do a Nassau Lean test, which is much more than many of us have in our houses. So it's leaning against the wall, heart rate, and blood pressure. And you can also do something called an active stand test, which is essentially lying down and then standing up, not against the wall for 10 minutes. And really, most importantly, you do not need to do a tilt table test. So what is your diagnosis? Well, you have a diagnosis of POTS when your heart rate goes up 30 beats per minute or twice in 10 minutes. Your blood pressure doesn't drop significantly. The symptoms are present for 3 months, and other conditions that can cause this are ruled out. So remember, it's although we're presenting this as a binary illness, either you have it or you don't, that actually isn't true. So tests are best done in the morning. But there really is a diurnal rhythm. So your results change throughout the day. So maybe in the morning your POTS test is positive, but if you were to do it in your doctor's office at 3 in the afternoon, it might not be. So there's a variability of how your cardiovascular system is controlled. So I want to introduce briefly some scoring systems to help you follow your illness. One is the Malmo symptom score, and this is a symptom burden quantification. In other words, they're looking at all the symptoms that can happen with POTS, and you use it for treatment response tracking, and you can use it longitudinally. MAPS score of greater than 42 is very sensitive, meaning will pick up most disease, and specific, meaning very good at detecting POTS. It fills a really key gap in that it's a disease-specific tool with semi-quantitative symptom score, so numbers, etc. So it was developed in Europe, in Northern Europe, and although many don't use it, it's definitely there. And I'm going to come back a little bit later and talk about the COMPASS score. So, you know how we used to talk about POTS and subtyping? And that really has fallen a bit out of favor. There used to be a push to put POTS into buckets: hyperadrenergic, neuropathic, hypovolemic. But that's really fallen out of the way. And we're going much more to sorry for the complicated slide, a Venn diagram approach where there's a lot of variability of how these symptoms can present. So in other words, they're not buckets, they're really overlapping syndromes. So high sympathetic symptoms will be like this. Neurologic symptoms may be as this, but they can occur together. And then they can also overlap with the hypovolemic symptoms. So you can see all these different variabilities that can occur in POTS. So we're kind of beyond the bucket stage. And the key point is there's a combination of all three symptom types with usually one more predominant symptom. Why it matters, understanding which symptom type is most prominent helps guide personalized treatment and management. So I recognize this is a very busy slide. So to make it as a little easier, again, you don't use these words, but hyperadrenergic POTS, neuropathic POTS, and hypovolemic POTS are the names we don't use anymore, but the illustration is of overlapping Venn diagrams. So commonality in symptoms, differences in symptoms. So this is the grading score for POTS and dysautonomia together, which was, sorry, those slides are a bit out of order here. So this is the Compass 31 scale, and it's a validated measure for self-administration, and it really tries to get a good handle on your autonomic symptom burden. So 0 to 100, with 100 being the worst. So this, unfortunately, this was meant to go with the Malmo POTS score, so I apologize for them being out of place. It's a really 1 to 10 score for 5 symptoms, and it tells you where you're at with regards to your POTS. So also good for helping with tracking. Now let's dive in to non-pharmacologic approaches. So I don't know how many times I've said dietary salt, compression garments, and exercise. Now, the dietary salt and compression I can handle. The exercise I leave to Trinetta because it's just not my area. So when we talk about salt, um, a lot of people ask, well, how much salt? And the salt is 10 grams a day. So how do you convert 10 grams of salt a day to something more tangible? Well, it's 2 teaspoons of salt in a Ziploc bag that you can ingest throughout the day and add it to foods. You can do salt water shots, and you can try salt tablets if you need to, because salt can be quite nauseating. So Vitacium is an option for gel coated. They can be expensive. So a lot of individuals will ask me, but what about electrolyte supplements? And so the key with electrolyte supplementation is to make sure that you can understand the labels. So the labels can be a bit confusing. So the ultimate goal is to try to get sodium into your body at about 10 grams a day. So you have to be able to convert from what the say hydrolyte label is saying, and there's so many different types that are available, and different kinds are better for different people. But this is sort of the as inexpensive approach that you can use. And I just wanted to highlight right here, I put this here on purpose. It's not just POTS, it's orthostatic intolerance. And so when we're talking about it, it can apply to when you don't quite meet a POTS diagnosis. So I want to give you a graphic on how does dietary salt in POTS change things. So over a week, which is pretty remarkable how adaptive our bodies can be. So this is a salt intake in someone with POTS, lower blood volume, as you can see. Their norepinephrine, that's the transmitter that works on the heart, cardiac stimulant. And you see all those little dots there? There's lots of them. That's in the synapses. So what do we do when that happens? When you stand, you get a high heart rate. As soon as you add more salt, within a week, your blood volume will expand. Also, you see already that your norepinephrine decreases. And the subsequent outcome is a slower heart rate and ultimately improved symptoms. So this is I think, an important illustrative slide that I like to use to just really illustrate what salt does and how it changes things. So compression garments. Now, I talk a lot about compression garments, and Katie Bourne was a PhD student who I worked with some time ago, who's now is finishing her medical school now. And she did this study comparing full compression versus no compression in when doing a head-up tilt test in the research lab. And you can see the difference in heart rate when you are purple and are fully compressed, and when you don't have any compression, you're blue. Look at the change in the heart rate with the compression. The compression will bring your heart rate down significantly. So really, I think to explain this, what's really happening below your chest, right as they hit the diaphragm, you're getting blood going downwards when it shouldn't be staying downwards. So compression starts at the lower limbs all the way up to the waist. And, that is how we can, in that external compression can help improve the actual blood flow eventually to your brain. So summer's coming or here. It's the worst time for POTS or orthostatic intolerance because you get that dilation of blood vessels and pooling, so you get more symptoms. So the tricky part about those compression tights, they're hot, they're tight. So if you have coexistent fibromyalgia with allodynia, meaning it hurts to touch, it can be really tricky. They can be itchy. Some say they can be ugly. The compression is 20 to 30 millimeters or 20 to 40 millimeters. So that's a fair bit of compression. If you ever want to know, put your hand in a blood pressure cuff and see what 40 millimeters feels like. Now, compression can sometimes be modified with high-end athletic gear, triathlon tights. You might get up to 18 millimeters of mercury. So here's an example. There's cons, it's not as much compression, but the pros are much more comfortable. They're more comfortable and a little bit more fashionable. I want to put a plug in here for waist binders because they can make a significant difference. Your body will drop its blood pressure into the abdominal area, splanchnic system, we call it. And often an abdominal binder, whether it be a corset, a binder, whatever you're using, can make a significant difference in the return of that blood volume. And it can allow you to eat without as much symptom involvement after eating. I want to talk about wedge pillows. A lot of wedge pillows, I think, are somewhat underused at times. And that raising of the bed actually is pretty important because it creates a chronic orthostatic stress. It's and we recommend it. What it does is it tricks the kidneys in a way. It decreases the urine output at nighttime, and there's something called the renin-aldosterone paradox. So aldosterone is a hormone that attracts water into the body. But unfortunately, they're not working properly when you have POTS or orthostatic intolerance. So that's why we call it a paradox. They're not working, but what you're trying to do with an orthostatic stress on a chronic basis is actually try to get this aldosterone to kick into gear a bit. So that's what they look like, a wedge pillow. However, sometimes you can do something called the poor person's variety, which is raise the bed. You can raise your bed up to 4 to 6 inches. See how you do it up at the top, and then that's cheaper. You can get a couple of bricks, than having to buy a wedge pillow and get it delivered to your house. So we've talked about some non-farm strategies, and I've kind of not gone into great detail because there's a lot of detail there because I wanted to get into pharmacology, meaning the medication support. So here is this busy table. And this busy table is actually the evidence-based table that comes from a journal that was the CCS position paper for POTS and related disorders. And although it's busy, I want to just make us some simple points, and we'll come back to this in a little bit. When we're going to pharmacology or medications, we're looking for the predominant symptom. Remember when I was talking back that it's a symptom, not a bucket. So you're looking for the predominant one in the presentation that you have. Is it tachycardia? Is it low blood pressure? Is it low volume? Is it more of a spiking blood pressure and a spiking heart rate? So to put this into more practical use, we're going to talk about more personalized or focused treatment. So probably the first thing we have to recognize in POTS, the blood volume is decreased by 15% to begin with. So we have to expand that blood volume. So if you can't tolerate salt, which I hear over and over again, and you can't afford the expensive electrolyte solutions, you may need medication to help expand that blood volume. So there's a medication that's been around for a long time called Florinef, and it belongs in the world of what we call mineralocorticoids. So it comes from our adrenal glands, but the drug itself is a mimic. So fludrocortisone, we use it for those that can't tolerate salt as well. It blocks the hormone aldosterone and causes fluid and salt retention. But there's always a trade-off, and the trade-off is you lose potassium and magnesium. So I always say when you take something, you may have to add in another thing. So if you can't do the salt, we do have medication that you can use. The difficulty will be that you're going to have to check your blood work, and that means lab work. And also, you have to really know that this may increase your blood pressure, and it may be too much, and it could cause a lot of swelling and fluid retention. And obviously, in the months where it's harder with POTS, you may get more. So let's talk about medications for people that have close to normal blood pressure in POTS. So you can do an additive approach, meaning Florinef if you can't get the salt in, and adding medicines, or start with one medication. So this is the medication called midodrine. So midodrine is used if you still have significantly decreased blood pressure despite salt or Florinef. So that's what I mean about additive therapies. It works as an alpha-1 adrenergic agent on the blood vessels themselves. It increases vascular tone. It means the tone is increased. They're squeezed a bit more. And you do have to be careful because when you lie down, it can cause what we call supine hypertension. So lying down, high blood pressure. And that is something we don't want. So we do not want to take this at bedtime if you're lying down for a long time, because your blood pressure may go up. And then you get into the whole category of high blood pressure related complications. So we kind of suggest when you're doing a midodrine agent, and I'm not going to go over dosing or things like that, that's more specific for our POTS group, you want to be aware that you have to monitor your blood pressure. So, what if your heart rate's really high after water and salt? Well, you want to think about drugs that um, block what's called a beta receptor. A beta receptor exists in many different parts of your body. And so non-selective beta blockers will help with POTS, but they'll also help with other symptoms associated with dysautonomia. So propranolol is probably the oldest that's around, and you can use metoprolol, a medium acting medication. Some people need only a morning dose. Some need it as needed. Uh, what is most common when you're using propranolol is the lower dose is more effective, because once you get into more higher doses, and this isn't like a sweeping statement for everyone, you can struggle with more fatigue. So some people find the higher doses harder to tolerate. And a little bit more on propranolol. It is in the beta blocker family, controls your heart rate, and treats dysautonomia. It works everywhere. It blocks adrenaline, so all the places that adrenaline works on your body. And when you're using it, you're hoping to target a heart rate of 60 to 70. Now, uh, unfortunately, we are unable to get the long-acting propranolol at this time because it's been on what we call back order. And that's likely because this drug isn't used in a lot of areas long-acting any longer. So that's one of the reasons why it's harder to get the long-acting. And so if you're going to use um, beta blockers that just target the heart, so in other words, selective beta blockers, they're cardioselective, meaning targeting the heart only. So they're only going to, they're not so good for all of the dysautonomia symptoms, so the physical manifestations that can occur with too much adrenaline. They're better for asthma, so you think of bisoprolol. So there's less evidence for these medications, but they still can be used with effect. So POTS, OI, and ivabradine. So for those who don't tolerate beta blockers or prefer given using the evidence that's coming from the long COVID world, there's a drug called Lancora or ivabradine. Problem is, it is not covered by Fair Pharmacare. It works on something called a funny channel, and it's specific to the AV node of the heart, which is the heartbeat generator. So it won't help you for the total gamut of dysautonomia symptoms. It again targets a heart rate of 60 to 70, and you can get fetal toxicity, so you have to be extremely careful in young women. And just as an awareness, we have to modify the dose when you're on Paxlovid. So another drug that we tend to use in many areas now is pyridostigmine, and it will block this enzyme called acetylcholinesterase. And by doing so, what it does is increase acetylcholine. So it will increase parasympathetic tone, which means that the slowing down tone or the rest and digest tone is more prominent, becomes more prominent. So in doing so, you can get increased blood vessel squeezing. You can help lower blood pressure, so you watch for your blood pressure. Improves GI motility, so it helps with gastroparesis, IBS constipation subtype, and those that have slow transit time. However, you do have to be aware that when you have IBD subtype, it can make it worse, and it will help in the area of ME/CFS, and it reduces fatigue and brain fog, and helps with muscle strength, So it can increase grip strength in ME/CFS. So cretostigmine, I just want to talk about that for a little bit. Um, the it's the same. The trade name is Mestinon. Once your heart blood pressure and heart rate are better controlled, it can be an add-on. It can be used in orthostatic intolerance with normal BP and heart rate, or when you have intolerance to a lot of medications. So methyl-dopa, I wanted you to know we've added methyl-dopa to our drug regime, and this is again an older drug. It's you consider methyl-dopa when sometimes when it's more of a higher blood pressure type POTS, and it will increase heart rate and blood pressure. So it also helps with dysautonomia. It works in the central area of the nervous system. So when you've run out of options, you're going to go to the centrally acting alpha 2 agonist. So big word name for methyl-dopa and clonidine. So it acts on the brain rather than the blood vessels, reduces the sympathetic output and therefore adrenaline, but it doesn't really help with nightmares. So again, what I've done here is I've taken this really complicated table and I've tried to make it a little simpler when you're making decisions with regards to drug therapies when it comes to POTS and orthostatic intolerance. So I've talked about a lot about the medications. How do you know that you're getting better? Well, that's when we start using these symptom scores. And that's where the Compass 31 is helpful. And so just if you want a reference for the Compass 31, again, it's validated in 6 domains and more of a dysautonomia questionnaire, but still very helpful for looking at general dysautonomia. So the um, Malmo POTS score can also be used. I've mentioned it before, and I'm going to mention it again. And it will be something that you'll find can be helpful in tracking and monitoring your symptoms. And it's because it's disease specific for POTS, it's really helpful in POTS itself to give you meaningful information that helps you understand, am I getting better? Is this working? So it might be something to add into tracking if you have space to do so. So I'm going to spend a little bit of off slide talking because some of my slides for somehow didn't quite make it into this deck, unfortunately. So one of the things that you didn't see is my slide that demonstrates the decreased blood flow to the brain. So in these conditions, there's a 20% decrease in blood flow to the brain. And so that's one of the core reasons why there's such widespread symptoms. And how do they know this? Well, because they've done what are called transcranial Dopplers, so measuring the pressure going to the brain. So you can imagine that 20% change in blood flow to the brain with these conditions is going to result in a lot of symptoms. And indeed, we've gone over them. The other thing I want to spend a little bit more time on uh, is long COVID POTS. So one of the things that long COVID has allowed us to understand a bit better is how viruses like SARS-CoV virus can trigger a number of mechanisms, and the method of treatment can be varied. So we first had ivabradine as the first drug that came on the market, but there's a little bit more evidence that there might be an association with autoimmunity. So there is a study coming and will be published in December called from the Recover Group in the United States. It's really looking at IVIG, which is a blood product given to individuals with POTS post-COVID, long COVID, to see the impact of that. So that study should come out in December, and it may be quite a change in how we treat. Now, the interesting part about that study is when to apply the therapy, if indeed the therapy is effective, because POTS can modify over time, and that's something that we've seen in the past with other viruses. So again, viruses have been post-viral syndromes or post-acute infectious syndromes, which seems to be the new coined term, has been associated with lots of viral illnesses, can cause POTS and related disorders. So we're going to be seeing more and more the wording of post-acute infectious syndromes as opposed to long COVID or other names that have been used. Now, I recognize that I have gone quite fast on this, but it gives us more time for questions. So I hope you don't mind. We're going to go on to questions. So I'll keep the slides here and let's go to questions. Hang on, everyone. I'm so sorry here. Let's see if I stop the share. So thank goodness Michael told us that he was hearing the discussion that Rick and I were having ahead of time. Sorry, we didn't see that. Do we get the slides? Good question. Rick, do we give the slides out or is it just the presentation? You may not be hearing me. I'll come back to you on that one. What does it mean when salt makes POTS worse? Despite worse dizziness, brain fog, heart rate, despite doing what I can for possible MCAS already? Now that's an interesting question because along with salt should come water. So it makes me wonder again, and I haven't gotten into the MCAS piece, but because I think that's a separate topic, but very important in the POTS world. If the salt is making the POTS worse, I would have to talk more about to an individual to really answer correctly, because perhaps salt really should be drawing water into the body. The only difficulty may be if you have a more high blood pressure type POTS, and then the salt can cause problems. So it's more of a individual titration when we're doing salt with high blood pressure POTS. With POTS meds, how do you know when you've reached your optimum maximum dose? So are we looking for specific reduction in heart rate or reduction of symptoms also? So yes, you're looking for reduction in heart rate. Remember, we were talking about reduction of about 60 to 70 beats per minute. Plus also you're looking for improvement in symptoms. And this is where the scoring systems that I included in this slide deck can be helpful because they can help try to tease out, are you getting better other than just numbers, heart rate? What to do if I was told I breathe like running during sleep at night? Is fully recover for dysautonomia possible? So I'm not quite sure I understand all of the question is, why do I breathe faster during nighttime? Well, part of that can be irritation of the diaphragm or irritation of uh, the lung tissue itself at the alveolar level. Is full recovery from dysautonomia possible? While you can significantly get improvement when they look at what we call longitudinal studies over time, you can see improvement in the POTS literature. Now, I haven't dove down specifically into dysautonomia in terms of what the longitudinal course will be. The one nice thing about the long COVID data is that we do now have longitudinal, meaning long-term data, say 6 years now. So looking into those registries would be very helpful. And there's registries in the UK that have over 2 million individuals. And it would be actually just diving deep into those, what we call cohorts, groups, and seeing what the improvement is over time. Next question. Can you talk about dysautonomia causing exercise pressor reflex? That's an interesting question, and I would have to defer to Dr. Arsenault, and I'm not sure if he's listening. Um, that one I'm going to have to look up myself. Um, so I can't answer it quite quick right at this moment. Any thoughts on the paper, Association of Post-Iliac Vein Stenting, Symptoms Improving POTS, Orthostatic Syndrome, Tachycardia Syndrome, Intolerance with Pelvic Vein Disorders, 2 retrospective studies? And can you talk about pelvic venous disorders and POTS and how we can see if we need stenting? So this is a complicated question. Because it involves likely, and I haven't read these papers, the combination of Ehlers-Danlos syndrome and POTS. Because the problems more with the connective tissue disorder is what often can cause the vascular piece that you're talking about here. So yes, the 2 problems can coexist together. And I think of the stenting as more used in Ehlers-Danlos compression. So I'm not sure if I'm answering your question correctly, but how need to know if you need stenting is actually fairly significantly detailed evaluation that may be out of the scope of what we can answer here today. Can MCAS cause POTS or only magnify it? So they used to say there was a variant of POTS that was MCAS related. So definitely MCAS and POTS are connected. I wouldn't say causal, meaning all MCAS is the only reason for POTS, but it certainly is a significant contributor to POTS. And that's why when you look at the website, it says treat MCAS first. And the reason being is once you've done that and improved your vascular tone and all the symptoms that can be improved with MCAS, that you can add on the treatment of dysautonomia related symptoms such as POTS. Do you need to perform a nasal lean test if formally diagnosed already? No, you don't at all. If you have a nasal lean that's positive, that's adequate for making a diagnosis. And I actually have spoken to a physician who is an autonomic specialist, well known throughout North America. And because we live so far away, it's hard to get to a doctor's office. Home testing has become acceptable. Now, if you look in the literature, there isn't the information there that will support sort of what we call a head-to-head trial comparing home measurement to office measurement. But I can guarantee you, because we've done it in hypertension before, that it can be done. Why it hasn't been done is the interest in POTS has not been as strong, whereas it has been in hypertension. So the question about understanding basis on the current literature is that the active stand test is a lot more accurate to diagnose POTS than the Nassau lean test. Are there any benefits of using the Nassau lean test instead? So they're not that different. I haven't found that information. We talk about using either an active stand or a Nassau lean. Why a Nassau lean is used is because it's supported against the wall if you get to the point that you're very lightheaded. So it decreases the risk of injury and falling. So the we do accept the stand and the Nassau lean as diagnostically equivalent for POTS. You may have read articles I haven't read though. Generally, symptoms resolve later in the day and totally fine in the night, terrible in the morning. Does this point to any mechanism or treatment? So, what it's pointing to is the diurnal, meaning the different time of day variability that can happen with POTS. Why you feel terrible in the morning is you're starting all over again with your salt and water loading. So the mornings can be tough, particularly if your POTS is worse in the morning than in the afternoon or late afternoon. So how would you manage this? Well, I would pay more attention to in the morning being more prepared for moving to upright posture. So uh, slowly putting your legs over the side of the bed, always having water at the side of the bed, either in a cool thermal jar. And you could use electrolytes, put electrolytes in there in the morning, and then take that 500 mils or so, wait for a bit, and then have a chair stand, and then slowly start mobilization and management of your day. So it doesn't actually point to necessarily different treatments. It just means that you're going to need the volume uh, uh, earlier in the morning. So is the Malmo something a patient would want to do? What is the value aside from just having data? Well, some individuals really value seeing symptom improvement. And sometimes when there's a numerical value improvement, that can provide more information. And definitely the Malmo score was actually created for the research realm. So definitely you may find that the you may not have a lot of value using the Malmo, but the reason I bring these things in here is for self-management and understanding improvement. Uh, is it normal for my long COVID and POTS symptoms to switch completely on and off? My readings are different from week to week. Yeah, it's a reflection of your disease process. So your condition is variable right now at the time of you writing this post, and you can have variation throughout the day. It's really pronounced in the summertime if POTS is a big part of your symptom profile, and it can be quite variable if you haven't achieved sort of a baseline consistency. So what do you recommend for those who do not tolerate dietary salt due to reflux? Are there other options? And this is where I bring in Florinef. It's really essentially a pill version that brings salt into your body. And with salt always comes water. So some people have terrible trouble with salt. And if the gel coated or the tablets or the hydrolyte or various solutions aren't working, that's one option. I wore very tight compression tights almost all the time in doing exercise. Ends up I have the ovary cysts rupture. Do you think it's related? Um, I can't say there's a causal. Um, if your cyst has ruptured, usually at the I don't think it's related because the abdominal pressure that you get um, the um, with the compression wouldn't cause a cyst rupture because that's a significant amount of pressure. And is it still a good idea if your ovarian cysts have settled and you're not getting the pain associated with that? For sure, it's still a good idea to wear. I have 5 centimeter kidney stone. Is it okay to take the salt? No, this is where this needs to be modified. So this, when you have stones, we have to be very careful with salt, and that's an individualized approach for someone who has a stone. Looking back, I've had POTS symptoms since I was 13, and now I'm 28. I don't have EDS or hypomobility, and I don't recall being triggered by illness or specific event. I'm wondering what the cause might be and if it could be related to hormones. I have non-classic congenital adrenal hyperplasia. So that's complicated. And yes, that could be involved. And it depends on the impact of that adrenal hyperplasia, meaning this how that's changed your production of adrenally based hormones. And so, yes, you may not have the typical triggers, but you do have a problem with your adrenal gland, which can be the location where many of the hormones are that control heart rate and blood pressure. 10 grams of sodium or 10 grams of table salt. This is always where I want to be clear. It's 2 teaspoons of table salt and 10 grams of sodium. If you ever are in doubt, just go to Google and look it up because I don't want you taking too much salt. If and when IV saline treatment is appropriate. So IV saline is useful when you're ill. Now, so we often, when you have a concurrent illness or another problem going on, IV saline can be a short-term solution. It's never recommended long-term because of the complications that can come along with doing so. So yes, in the short term, it's a possibility, especially with a concurrent illness, but never long-term. So 10 grams of salt. So it's 10 grams of sodium. This is why I say the conversion gets tricky for everyone. So you're looking for sodium, and that's why it's getting a bit confusing here. So I always say 2 teaspoons of salt to keep it consistent. That's a good rule. 1 gram of salt is 400 milligrams of sodium, 10 grams of salt is 4,000 milligrams of sodium. If you're calculating for POTS or dysautonomia management, 10 grams of salt provides roughly 4 grams of sodium, which is within the range sometimes recommended by specialists for some patients, though individual targets vary. Yes, individual targets can vary. And again, it's representative that POTS is all not one syndrome. So some are more volume sensitive. What happens if you just go to the bathroom more when you're taking in more salt and water? So if it's urination, we can look at that in a different way. You can change how you're taking the salt and water in. You could do salt and water and lay down. And sometimes we have to look at other drugs, which would be more of a question that we'd answer in the dysautonomia POTS group. How to improve shortness of breath from dysautonomia? Well, this is a tricky one. because it isn't anything that's easily treated. So again, it's related to the changes in the nerves going to the small airways and to the muscles and the side of the chest. So it's not easy to treat. And uh, I wish I had a better answer, but it isn't easy. What are steps to potentially address if pelvic congestion syndromes are a factor? So I think this is where we have to separate illnesses here because the whole area of pelvic congestion and pelvic related disorders I haven't factored into this talk. So it is a sort of a separate issue that I might have to talk about in a different time frame. What level of compression garments, if 40 millimeters, should be worn for very severe orthostatic intolerance? So 40 millimeters is about usually at the most anyone can tolerate. So that's the upper number. It's cumbersome, they're thick, they're itchy, but that is the upper number. I don't have any noticeable symptoms. I meet the criteria for hyperadrenergic POTS due to substantial blood pressure increase upon standing. Now, the Nassau lean test doesn't measure blood pressure rise. Do I have POTS? Does this need treatment? So this goes back to what I was talking about the umbrella of orthostatic intolerances. So when you have transient increase in your blood pressure over 3 minutes or 5 minutes, that may be orthostatic hypertension. Now, a Nassau lean test does have the blood pressure component in it, the heart rate and the blood pressure. Often we don't do it on the same day, but it is included in the Nassau lean. How do you know if you have POTS? Again, the definition for POTS is quite specific. It's a heart rate change of 30 beats per minute over a 10-minute time frame with two successive readings of a heart rate change. It's in the younger age set, it's 40. So does it need treatment is whether it's actually prolonged. So this is where this would require a bit more monitoring to determine if this is just initial orthostatic hypertension or a more sustained hypertension with heart rate changes. Can we confirm the dosage of salt? 10 grams of salt or 10 grams of sodium. So I always go back because by the time I'm here, I'm starting to get a bit tired. So
Let me
yeah.
chime in. I always say 9 grams instead of 10 grams. Same thing. But the reason I say 9 grams is for comparison.
Mhm.
So if we look at 9 grams of salt in 4 cups of water, that's 0.9% normal saline. So it's actually the same as you get as a bag of saline.
Oh,
Nine
sorry.
grams of salt is a big heaping teaspoon, and 10 grams of salt is 2 flat teaspoons. So it's actually grams of salt. And it's about 40% of that is sodium because the other weight comes from
Chloride, yeah.
chloride. Yeah.
Yeah, so that's a good way of looking at it. And this is where it gets so darn confusing. So, yeah, the 9 grams in water gives you a liter of normal saline, which is what is isotonic, which we use in IV fluids, of course, created sterilely. Let's keep going here. Oops, apologize. Do you have any brand suggestions for prescription compression tights? So it really depends on your home health. Sigvartis is a big one that produces compression tights. That's the one I usually think of, but there may be cheaper brands that are now available. But that's the one I often think of when I'm suggesting prescription tights. Sorry, keep going. If affecting norepinephrine is a good thing for POTS, OI, via sodium intake, and ADHD stimulants often affect norepinephrine as well as dopamine, how could taking ADHD meds, that's a great question, affect POTS? Well, it does. So ADHD medicines do affect POTS. The thing is, I always say don't stop your ADHD medicines. And the ones that are the worst are, um, uh, I think it's Strattera isotretinoin, the one that is the worst. So yes, they can affect your POTS, but I'd rather have you treated for your ADHD. So we work around it. Do waist binders, corsets have an effect on gut motility or gastroparesis? So remember, you're providing compression, enough compression to try to improve the splanchnic blood flow, but gut motility is controlled by different mechanisms. So it may not have an effect on gut motility or gastroparesis because that's related to direct innervation to the GI tract from the autonomic nervous system. So waist binders aren't altering the autonomic nervous system, they're altering the consequence of the autonomic nervous system. Okay, here we go. A little confused about the distinction between salt and sodium. 10 grams of salt, but you mentioned aiming for 10 grams of sodium and electrolytes. So this is where sometimes I think I should just talk and use Rick's analogy. So, uh, so the salt is 10 grams a day. So the sodium is less. 2 teaspoons of salt level is about, as I said, Rick said about 5 grams of salt. And so I'm sorry if I'm getting everyone confused with my slide deck.
So each teaspoon is 5 grams, so that's 10 grams level, and one
Mhm.
heaping teaspoon is 9 grams.
Right. So I'll be a little clearer next time. I just stick to teaspoons so I don't get confused. Would adjustable bed be better than a wedge pillow? So the tricky part about an adjustable bed is you're only raising the head and the torso. So it will help some, but not as much as actually just lifting the head with blocks. Some people do get benefit from an adjustable bed, but your bed can't go up all together usually. They usually go up front, up, back, bottom. So, that's why we suggest if you're not going to get a wedge pillow, maybe the bricks might be an answer. So, do we know the likelihood of having POTS on its own rather than a symptom or association with another condition? I, uh, I'm as sure as I can be that there is more going on for me, but other than chronic fatigue, I haven't found anyone willing to assess other conditions, including POTS. I know from my own research that I meet criteria. Is it possible to have POTS alone? Yes, indeed, it's possible to have POTS alone. It often occurs with other things, but it can occur solo. Um, so I hope that helps. How does the body all of a sudden develop POTS? Um, so it's it's not often an all of a sudden thing unless you've had the brain injuries that you've talked about. It is something that can develop in childhood. It can develop in young adulthood, and it can surely come along when you start to have concussions and then viral insults. Would edema in a leg or the legs be a sign of a eye? Well, it depends on the situation. Edema can occur in a lot of the orthostatic intolerant conditions. So, but I always want to make sure there isn't something else going on before I attribute it to that. So it would require a few more questions. What are the signs a patient should switch from Vitacium to Florinef? Well, really, if the Vitacium isn't working and you're not getting the volume in and it doesn't seem to be making a difference, it's worth a trial of Florinef for sure. After taking zero point 0.5 milligrams of Midodrine and started having chills for 20 hours, tongue swelling, but blood pressure decreased, normal, or should I don't think you should try Midodrine again if that's happening. How concerned should we be about the long-term effects of high sodium intake with regards to chronic high blood pressure, heart disease, etc.? So it's a really good point. And uh, Westernized diet with high salt has increased the prevalence of hypertension. But, and this is where it's tricky. So POTS and orthostatic intolerance are conditions that need more salt and water. Does that mean that's going to cause hypertension? It's hard to make that causal jump, but excess salt in the general population is a component to causing high blood pressure. But there's many, many more things going on than just the salt. Um, However, you do need to watch your blood pressure over time as the risk for hypertension goes up as you age. Heart disease and hypertension can coexist together. Uh, the um, so definitely there is a correlation between hypertension and cardiovascular disease. With orthostatic intolerance and MCAS, how do you deal with pitting edema in lower legs worsening from antihistamine? Well, that's an interesting question. I guess the first question is, um, was it reproducible? Like, did the antihistamine actually cause leg swelling right away? And that's kind of how I would try to sort that out uh,
That,
from
that's
logically.
that's interesting, right? Because
Yeah,
often it's MCAS itself that causes the swelling.
yeah,
Because when Dr. Nikki was at her worst and her MCAS was like unbearable, she says she had 20 pounds extra of fluid. And so, you know, it's interesting because when she treated her MCAS, the fluid went away. And then she was able to tolerate salt to treat. And that's why, again, why we put MCAS first. But I'm just going to look it up. I've never heard of,
yeah. Honestly, I haven't either, and I think I've memorized every side effect of the drugs we prescribed. So, be interesting to see if there's a paradoxical thing that can happen. I'm already taking ivabradine, midodrine, pyridostigmine, and clonidine, but still have significant symptoms to the point I use a wheelchair.
so
I did
Jane, I
not.
just looked it up,
Uh-huh.
did a Medline search, and it says antihistamines are highly effective for treating histamine-related edema, and they do not cause edema. So it makes me wonder, like you said, is it a paradoxical response? But it's not something that I've ever seen.
Right. Yeah. So, getting back to the next question, I'm already taking ivabradine, midodrine, pyridostigmine, and clonidine, but still have significant symptoms to the point I use a wheelchair. I didn't do well with a beta blocker, fludrocortisone, and my POTS neurologist is at a loss of what to do. Yeah, so this is a complicated case, and first principles first would be, is the sodium or equivalent intake adequate with the fluid? And the other second piece would be, I would think more of adding alpha methyl dopa in this situation because clonidine doesn't work as well. So this is where I would probably use if alpha methyl dopa 3 times a day, I would think. But then the other thing, when I see this much medication on board with POTS, I also wonder what's happening at the kidney level. So, you know, in terms of salt handling. and potassium handling. So, and the reason I say that is a fludrocortisone intolerance. So, um, I'm, I would, that's my only thought as an internist. You think broad, right? So, in this situation, the medication I would take is suggest there's two options here. One is alpha methyl dopa, and that one sometimes is better because you can split it up throughout the day. Or you could try
Yeah, what's
guanfacine as
there?
well.
Guys asking, should we meet at the restaurant or you?
No, I
Oh,
can
we
come
got some
from there.
background noise there.
No.
Can you explain why unquenchable thirst can happen with these conditions? So I took those slides out, but you can either be not thirsty at all or really thirsty. It depends on what the concentration of the fluid going into the brain osmolar receptor area. So it and that's so it's difficult to find that out without doing specific testing. But the unquenchable thirst can happen. But always remember, is there any side effect of dry mouth from anything else? Because that can be perceived as unquenchable thirst as well. So those are the things I always think of when I get asked that question. What does target of 60 to 70 mean? What time and what times is this? So this is an average, right? No one's going to ever be perfect having a heart rate of 60 to 70. We're saying on average, if you can get your heart rate down to 60 to 70 most of the time, we're doing a good job. But remember the variability of POTS and diurnal variation. It can be all different in the evening or afternoon than in the morning. So the heart rate changes will reflect in that. Is the heart rate 60 to 70 while standing? Yeah, it's while doing activities that you want to have a more controlled heart rate so you get better blood pumping and higher stroke volume from your heart. Resting, this is a note. Sometimes your heart rate will go, not sometimes, your heart rate always goes down when you sleep. So at night, you may have a lower heart rate than 60. I have a full under pressure, heavy, overloaded feeling like a balloon ready to pop or a plant pot overflowing. My body feels overwhelmed by extra medications, supplements, and foods. 8 foods, MCAS. Worse standing for too long, worse sitting for too long, and much better after laying down. I have MCAS and MCS symptoms as well. Everything I tried makes symptoms worse. Upping salt definitely has helped, but compression garments have made symptoms worse. You're getting leg cramps and pains. My body feels just at capacity all the time. Would you have any advice or suggestions? I would really like to gain some weight and eat more foods. So this, the root of this is I wonder if the MCAS is fully or adequately treated. Because remember, Dr. Arsenault just gave the example of Dr. Liz, and when her MCAS was treated, it made things significantly better. The full pressure feeling may be coming from the MCAS component. There's a lot of things going on here. Now, any advice with regards to food? So this is where I always suggest Michelle, and it talks a lot about how to get food in when you're restricted with MCAS related foods. So she is a great resource. Is clonidine no longer used for POTS? No, it can be used for POTS. It's just that we find in feedback that it doesn't work as well. So the tricky part about clonidine is it's very short acting. And so if you're going to use clonidine, you do have to use it up to 3 times a day at a fairly significant dose. And that can sometimes be problematic. So that's why we're using it less and less because it's harder to take all of those doses throughout the day and you could drop your blood pressure as well. TLDR question, is there anything I can do to reduce reliance on IV fluids through my PIC on major flare days when all the discussed remedies aren't working and I retain water? Well, that's a really tricky one. And I think that might require maybe a group medical visit to answer a little bit more effectively, because it would be teasing out what's done, what hasn't been done, if the MCAS has been treated, uh, and retention of water. So it's not an easy question to answer on the fly here. Come to a group medical. I have a pick to administer gravel and Zofran through the day to severe nausea and GI symptoms when I drink, as well as lack of emotional regulation related triggers. I add salt orally, however, I retain water. IV fluids have been found to be the most effective way to keep my hydration at a sane level. I don't have a doctor yet that can help me figure out one-to-one what could I do to reduce my IV fluids with the retention, kidney bladders related issues I'm known to have. I'm on other meds orally to manage my POTS, MCAS, hypermobility, ME/CFS, fibro as well, which helps, which helps reduce the reliance alone. But I cannot keep up in the summer heat despite all my efforts. I still end up with severe pre-syncope, syncope, major GI flares, taking days to recover, even with IV fluid. Well, that's a tricky case. And it's a hard one to answer in a group setting because there's a lot going on there. And probably the best would start bringing it to a small group, and then we could see if we can parse through the best things and best options, or find you a person that can help you the most. Do any of the POTS and OI treatments result in improving GI function for those experiencing GI issues? So the one that comes to mind is Mestinon. So Mestinon can help with gastroparesis, can help with IBS constipation subtype. So Mestinon is the one that I think the most of for GI help. Do you have any thoughts on the Lumia 2 coming to Canada for tracking blood flow to the brain? I don't know much about the Lumia 2. I don't know if Rick knows more about it, but I'd have to actually look at it. Because really would need to know if it compares to the gold standard. And the gold standard that we have thus far is transcranial Doppler. So I'd have to look at Lumia 2, what it is, how it compares, to really say the efficacy. I don't have POTS. I did the Nasoline test with my OT, but I have dysautonomia symptoms. One of my flare symptoms is vertigo. When that arises, I use electrolytes. It seems to get better. Exactly. So do I need to include salts all the time or only when symptoms present? So what you're seeing here is orthostatic intolerance. So associated with dysautonomia. Do you need it all the time? You may need it some of the time. You may need a smaller level all of the time. So it's really just playing around with it to see what's the best fit for you. Will your clinic be prescribing IVIG and published in December showing a valid therapy for long COVID? Now, I'm still waiting for the Recover studies, and I'm waiting for a little more information and uptake before we even can envision IVIG therapy. So that's not made the mainstream yet. Is it common in people with POTS for certain beta blockers to slow the heart rate too much or interfere with the electrical signals to the heart to the point that it causes syncope without any warning? So this is a red flag, and this is making me wonder if there's something wrong in the conduction system. So that would trigger me to want to do further testing, because yeah, that requires more investigation before we could really provide a fulsome answer. Can POTS come and go? Absolutely. can come and go. Diurnal rhythm. Uh, Thanks. Great talk. Are night sweats part of these syndromes? Yes, you can have night sweats for sure. You can get pseudomotor. Remember, I talked about pseudomotor for sure. Pseudomotor and symptoms can occur. Um, Wondering about your mention of POTS modifying over time. Is there any historics on this? Well, this is a really interesting question. So again, we're looking at longitudinal data. So remember, everyone, POTS was defined in 1993, and not many people paid attention to it. And Dr. Satish Raj and Dr. Andrew Cron talk about it all the time. They're the only ones sitting in the back of the room at the Autonomic Nervous Society conferences. So not many people are that interested. So I can't say um, uh, with impunity that your POTS is going to get better over time. But what some indication is that it can get better over time. So it's kind of a weird answer, but that's about the best that I can give you. I'm curious whether the medications that primarily control heart rate and POTS do anything to address cerebral blood flow and related symptoms. If I am correct in understanding that the elevated heart rate on standing is a compensatory mechanism, how does keeping heart rate lower address the underlying physiologic issue with blood flow pooling? So remember, drugs are added on after salt water compression. So once you've done that and improved your blood volume, increased the circulation to heart, then you slow down the heart rate. What happens is there's more filling time in your heart. And when there's more filling time, no more blood goes into the heart. And when the heart pumps, out goes more blood forward. So that's why it's and the cerebral blood as well. So that's why saltwater compression is what I'm always saying first. Is I have a restrictive eating disorder. On days I struggle with eating enough foods. Is 10 grams of salt safe to aim towards? Well, this is a bit of a hard question to answer because it requires a little bit more understanding of the restrictive eating. Uh, those with eating disorders can have POTS. And we do treat with salt and water and salt shots and things like that. But I think I would say that requires a little bit more information to say with impunity, just go for the salt. Can long COVID produce inflammation of the adrenals, resulting in aldosterone renin dysfunction, causing these symptoms? So it's a really interesting question, and so in essence, we're talking about post-acute COVID sequelae because we're talking about, is this a tissue-based disease? And is this in the adrenal glands? So I haven't seen any pathological information on looking at the adrenal glands. However, I haven't gone searching for it. Now, can it alter aldosterone and renin? Yes, absolutely, but in a different mechanism for sure. I notice my POTS symptoms get worse if I'm doing a task where I bend my neck downward for some time. Can POTS be made worse caused by abnormal anatomic structures in the neck? So in a way, yes. This is kind of a complicated question, but positional change in itself. So if you bend down or change your head neck position and body position, your POTS symptoms can get much worse. And that's in part to what's happening when you do that. There's something called you're creating a Valsalva maneuver, and that's causing changes in your cardiovascular physiology. Now, whether or not you have a cervical neck issue is a different discussion. Best I could do. For midodrine, can you not lie down at all while the medication is active? No, not so. So we usually say check your blood pressure when you're lying down. If you're lying down most of the time, we probably would only use midodrine with caution. So midodrine we often are using if you have periods of upright posture. I hope that helps. Do you have suggestions for fluid loading when it seems to go right through? Yeah, so this is where I was talking about with you can do different types of getting salt in. Salt shots we can use where you get more salt than water. You can do salt water and rest for a bit. Some suggestions that might help with getting your fluid in and getting your fluid in sort of over time throughout the day, not in big chunks, is a good thing. Um, how do you help calm symptoms that worsen the week before your period? So this is um, where hormones can play a part. You can have alterations in your orthostatic or dysautonomia with related to hormone fluctuation, and that would require looking at a strategy for treatment at different times in your cycle. Have you noticed patients doing better at lower elevations, like at sea level? I seem to do better when I'm away than while where I live in BC at 4,000 feet. Hmm. So atmospheric pressure will alter oxygenation and such. I really can't say with significant confidence that 4,000 feet will make a significant difference. I can't say that. Is it common to have lower BP in the evening? I generally measure 110 on 70, but after 8 or so, I measure 85 on 55. Yes, your blood pressure usually dips in the evening and at night, and it's called dipping. And when we're looking for cardiovascular disease and you're a non-dipper, and I'm doing an ambulatory blood pressure cuff monitor, I'm looking for that. So normally your blood pressure will dip in the later part of the day, evening, night. I take bisoprolol and recently went from prazosin to guanfacine. The guanfacine helps brain fog, but it doesn't help my severe adrenaline surges and hot flashes like prazosin did. Is it possible to take guanfacine with prazosin and bisoprolol? In this kind of a situation, I wonder if straight up propranolol would be better than bisoprolol because bisoprolol is a cardioselective agent. And then you can combine guanfacine and prazosin together, but my only concern is the effect on its blood pressure. So I think I have the hyperadrenergic symptom cluster mostly. So guanfacine would work. Prazosin can help for other things, but the beta blocker, if you're not getting dysautonomia help, I would probably go back to straight up propranolol. I have lipidemia, connective tissue disorder in POTS, HEDS, and I've been wearing compression tight yoga pants to the waist for the lipidemia. I'm wondering if you know about adding arm compression. I'd like to add it to help control lipedema on my arms. I'm imagining it would help POTS as well. So it could. I think it's going to help more of the lipedema than the POTS because it's usually, you think of your arms above your heart, but it may have some effect on your POTS. You recently started using electrolyte packets in my water when playing table tennis and has definitely made a difference with with dying with difference with something when I bend over to pick the ball. So that's great. I'm glad it's helping. Where can I get more info on exercise as a treatment for low blood pressure? So I rely on Trinetta a lot, so you can see her individually through CPR Eye Health. For low blood pressure, it wouldn't necessarily be covered in my POTS group, but it definitely could be seen on an individual basis. What is considered too high blood pressure when you shouldn't increase your salt for your POTS? So again, this is a tailored approach. And so the salt I recommend when I have someone with pre-existing hypertension or a lot of hypertension varies, right? So it's really depending on the effect of the salt on the blood pressure, salt and water on the blood pressure. So it's never the same as POTS without hypertension or high blood pressure. If increasing sodium increases intake causes excessive urination, is this related to not enough sodium? Um, so with the sodium comes water. Um, the excessive urination may be the amount of blood flow going to the kidneys. It's probably not so much the sodium rather than I think you need to change your position a little bit. And this is where I say you may want to do some lying down in the daytime to decrease the degree of urination that's happening. When do you know it's time that lifestyle salt and compression isn't enough and you need to turn to pharmaceuticals? So it's really a personal decision about how symptomatic you are. And when your symptoms are interfering with your ability to live your life, is when I would think pharmaceuticals need to be thought of. You mentioned nightmares. Is that a potential symptom? Nightmares can occur. And I'm glad it helped you. What's the position for heart rate? It's 60 to 70. And remember, it's going to go down at nighttime. Dizziness with a star. Dizziness can happen. Is more than 10 grams of salt ever recommended? I have difficulty drinking more than 2 liters of water per day as I already have to use the washroom very often. Should I increase the salt to help retain more fluids? Geez, I think in that situation, I might want to add in compression and medications. Because it seems like the salt that we give you, we recommend it should be enough volume expansion. So, I would start thinking, especially if you can only get 2 liters of water in a day. And then if you're struggling to get water in, you may want to think of water equivalents like yogurt, um, um, soups. Those things bring fluid in as well. And if you're struggling with water, the other thing in addition, would be popsicles, ice cubes, slurries, things that will be water that aren't quite as challenging as water on itself, because some people just can't drink water very well. What can be the cause of heart rate spikes during sleep? I sometimes wake up to my watch alarming at 130 beats per minute when my heart rate is 40 to 50, and sometimes when I have too much fatigue, I get wakeful. Yeah, heart rate changes can happen. Normally, if I'm hearing about heart rate spikes at night, I'm starting to think about needing to do a little bit more investigation as personally, because I wouldn't mind seeing what's happening. You will get more. If your heart rate goes too low, yes, you're going to have more symptoms. Yeah, so everyone's talking about the urination. The reason the urination is happening is more salt and water together increase your blood flow. That increases blood flow to the kidneys as well as the brain. When the kidneys see water, they start to excrete it, right? So that's one of the reasons you're going to see that. If you do a nasal lean and get close to 30, does it count as POTS, say 26 or something? Remember, varies in the day, orthostatic intolerance. So POTS is a very binary, you're in, you're out. That's why we have this POTS light, you might hear Dr. Arsenault say, or more orthostatic intolerance, or do it at a different time of the day. 26 is pretty close, but the actually true definition, if you're following the textbook, or no longer textbook, the electronic paper, it's 30. That's the arbitrary decision made. On the medication handout for Midodrine, it says to increase the dose by half a tablet per dose at a, at, at a time once a week. Does that mean I would go from a half tab to 3 tabs a day for a week? Um, so I think with the Midodrine, I wouldn't jump that quickly. I'd look at the medication handout. Usually we start differently. Um, you may want to start one a day, half a day. So the going up to 3 times a day, a full tablet or the full dose, I wouldn't do it really like quickly. Um, so you could do it what you've suggested, a half tab 3 times a day for a week, then full tab one day and half tab 2 other times the next week. That's a possibility. So what this speaks to is individualization and how you treat things. So everyone is very different, and how you adjust your medications will vary as well. So we try to give it very descriptive recommendations in the medication handouts. If at all confused, please come to a group medical visit. I am very convinced I have MAX and POTS. I wonder if that's MCAS and POTS, and have for years. However, I have low blood pressure and worsening edema. Yes, you would have low blood pressure and worsening edema if you had MCAS and POTS. Yes, definitely. I had a provider say they didn't think I had POTS because my heart rate wasn't high enough over 100 to be concerned, but every time I do sit stand at home, I have a sustained increased heart rate. I thought the level of increase was key and haven't seen anything about how high over 100 has to be. Is it supposed to be a criteria for POTS? So I say a delta of 30. I don't actually use the 120 number. So you can be 60 to 90. I don't think that it has to be tachycardia always above 100. And so I think there's some leniency in making the diagnosis, but it can be difficult when you have a provider that doesn't see this at all the time, right? They're trying to apply one definition to you when there's variability. Does energy increase right before bed have to do anything with POTS alongside restless sleep? Is there any way to manage those symptoms? Um, So I guess the question is there variability in the POTS? That would be my first thought. And then it's also about individualization. Like, do you need more treatment for POTS in the morning rather than the later evenings? And restless sleep can be many things. So I wouldn't say it's just POTS. Um, I make my own electrolyte mix using table salt and low salt, weighed upon a microgram scale and packed into small single dose containers to be mixed into 1 liter of water. Uh, is there a general rule of thumb for sodium potassium ratios to stick to get the best symptom relief? How do I know if I'm having too much potassium? Is there an absolute ceiling for how much sodium someone with POTS should consume in a day? So again, always remember potassium, right? Potassium normally, if everything's working well, will be excreted in your kidneys. But I always use the analogy of 75 milliequivalents in, 75 milliequivalents out. So that's your intake and output. Now, we stick to about the 10 grams of salt, 10 grams per day. Can you go over? Well, then you just have to make sure. I don't normally recommend that uh, as a rule, but yeah, I usually stay away from going up much higher. If I meet the diagnostic criteria for POTS in terms of my heart rate, but I also meet the diagnostic criteria for NMH, does that mean I have POTS and MNH or just? So we don't use the term neurally mediated unrestricted hypotension anymore. We've gone away from that. So we would say POTS or variation of orthostatic intolerance. Any thoughts of the use of nicotine patches along with salt loading and long COVID? Uh, so nicotine patches have been studied now a while ago for the use in POTS and, or sorry, in long COVID. There was a small study that did show some improvement. Now, can you use it? Sure. I'm not going to be able to guarantee that the nicotine patch and the salt, water, and compression are going to make a significant difference. Does Fluoronoff block aldosterone or augment? If it blocks aldosterone, would it not have an adverse effect of POTS? Sorry, I'm confused. So this is where so Rick, Fluoronoff is an aldosterone antagonist. Are you there, Rick? I can understand why you're confused. Um, just give me 2 seconds here. Uh, by 6:30, I'm getting a little bit tired. So I'm not sure if I'm answering this question correctly. Fludrocortisone or Florinef is converted into the liver. It's a prodrug, and it's a synthetic adrenal steroid that has high mineralocorticoid activity. That's how it's working at the kidney level to retain sodium and cause water retention. Now, so aldosterone regulates blood pressure by fluid balance by promoting sodium resorption and potassium excretion. So remember that aldosterone paradox thing I was talking about? So when you have um, these conditions, you have the aldosterone isn't at the place that it should be. So fludrocortisone is sort of like a substitute. I hope I've got it as correct as I can. Do you have any opinion of experience with stellate ganglions blocks improving OI dysautonomia symptoms? So they definitely will alter dysautonomia symptoms. And if you look at stellate ganglion blocks, uh, just a second here, I'm just doing a quick search. What they're doing is they turn off, so they're injecting a local anesthetic into a bundle of nerves in your neck, and it's used to turn off or reset the sympathetic nervous system flight fight response. So where does it help? Anxiety, PTSD, chronic pain. It has definitely been used in uh, long COVID for sure. So the it will help with the dysautonomia symptoms, and indirectly it will help with the OI by altering the sympathetic flow. But that one's a bit tricky because of where that ganglion sits, that nerve sits, right? Because the whole chain of nerves is distributed along the spinal column. So, how much effect on orthostatic intolerance would vary. Does this program have an ER treatment document for POTS OI MCAS patients? We don't, but it's actually a pretty good idea um, to work on. Thank you. So the doctor said I have orthostatic intolerance and symptoms of MCAS, but I haven't done the Massillene. I have dizziness every day and sometimes accompanied with palpitations, shortness of breath, especially when going up the stairs. I have a kidney problem and controlled BP, but sometimes BP is high. What meds or treatment would you recommend? This is an individualized question because you have comorbid issues that need to be managed together. So this can't be answered in this setting. Again, this is somewhat of a similar question as before. My symptoms seem to increase significantly during the time I get my period. So that's again like having so sometimes we talk about having a sick day routine. Some days you can think about it having as a cycle routine. I take metoprolol. Should I still do the salt thing? So if you're only using metoprolol and not doing any other treatment, you may not be getting full symptom control. I find myself drinking 6 to 7 liters of water a day because my body's asking for that. Is this the body trying to increase the blood volume? That's a tricky one because I would want to know, first off, is there any other reason? Is it dryness in your mouth? Is it anxiety? Is there anything that's asking you to drink 7 liters of water today? Because the converse can happen if you drink too much water. It can drive your sodium down. And then if you do that, then it will alter a lot of things in your central nervous system. So the water, just be careful on the water intake that you're taking in. And then you always have to think of, well, why am I drinking that water? If it's not dry mouth, it's not for another reason is a diabetes. That's the other reason I think of a lot of water intake, or another condition called diabetes insipidus, which is a kidney related disorder. So that requires a little bit more attention. Well, you be giving a lecture on MCAS. We are doing a lecture on MCAS, but I'm not doing it. Dr. Arsenault is. Resource, DI, Dysautonomia International has medical accommodation wallets that explain POTS. Yeah, it's a great site. I recommend it all the time. I didn't put it in this particular slide deck, but Dysautonomia International, POTS UK, the POTS Project, there's a few sites that have information. I do find that Dysautonomia International has a lot of helpful stuff for North America. POTS UK, obviously UK site, so variation. Is there anything that can help the nausea with POTS? Yeah, that's a tricky one. Ginger gravel, avoid regular gravel. Good reason because gravel itself slows the gut. So ginger gravel's okay, but I wouldn't want to use regular gravel. If you're having a lot of nausea with POTS, I would start thinking about mestinon as an addition, if at all possible. Why does mestinon help with IBS-C? Its effect on the bowel. It essentially causes constipation. Uh, I have blood pressure jumps that are up and down. I use guanfacine. You get pulse alerts in the low 40s. Yes, guanfacine lowers your heart rate. Even when I think about stenting, my blood pressure jumps. I'm getting better. My ADD is much worse. A big problem than ever. Just weaned off Adderall. I'm feeling a bit stuck not knowing what to do next. Compression works, and I'm trying to figure out what to do with salt. I just don't know how to proceed with. Okay, so when you have high pots with high blood pressure, that requires a more finessed response. So pots that has a hyperadrenergic component, you're going to be using uh, salt and water because you're still hypovolemic. And you also are going to have spikes, and you could have spikes in your pressure and your heart rate. And this is the group of medications that we use would be guanfacine, alpha methyl. Sometimes we will, if we have to, add clonidine. That grouping of medicines is the ones that we use for a more high blood pressure pots. Can I use sea salt versus table salt? Yeah, I just don't know the conversion. I get asked this a lot. I think whatever salt you're getting in is some sodium is what you need. So if you want to avoid iodine. Okay, about the PICC line, I heard. Uh, so again, the question about sea salt versus table salt. What about microdosing GLPs for POTS? Well, microdosing GLPs is a big topic, and we are going to address it, so stay tuned. I was diagnosed with POTS on a tilt table, was taking 10 grams of salt water electrolytes, but after a while I started to get swelling. I wasn't diagnosed with MCAS though. I'm guessing I need to determine that first. So you will get swelling with salt and water, but you could have MCAS. That's a very good thought. Can you clarify the goal of 60 to 7 heart rate? When standing or lying down, remember it's usually with upright posture. With time and laying down, your heart rate goes down. Do you write prescription for compression tights? Yes, we do. And usually you send a note to one of our assistants and come to a group medical visit. How many teaspoons of salt per day? Uh, again, I don't want to confuse anymore. 2 teaspoons. Why is Terra the worst ADD? Because of the way it works. It has uh, I don't have the pictures to show it to you how it interferes in the norepinephrine pathway, but it is the one that's the most challenging. Stoco is a great brand for compression tights and shorts. They're fashionable. They're now classified as a medical device. Oh, is that interesting? I didn't know that. And will be covered by insurance plans. Well, that's great. Good news. Uh, so can perimenopause alter and affect symptoms? Definitely. Um, so if you're starting salt for the first time, you may want to go a little bit slower because it's going to take a while to get used to it, the taste particularly. Uh, Question about tapering your nighttime beta blocker. Yes, you can taper it. My H2 has been working remarkably at decreasing my heart rate, and I've been dipping into the 50s. Yeah, it's totally fine, what you've just asked. I'm hypermobile and severe MCAS. My fluid retention is severe. When my fascia is too tight, I very much need magnesium. Also, fascial release by a professional. Okay, thank you for that comment. It is a miracle to have below 70 to 40 BP when laying on the bed, specifically leaning to the right. Is it I'm not quite sure I understand the question. My heart rate is low 70s when sitting and lying down, but if I walk, it goes to 120. Do I need to up my bisoprolol? So if you're symptomatic, you may need higher. So transcranial Dopplers, actually, I don't even know where they're doing them, and I don't know if we can get them done. I see them really in the research studies. I don't see them in a test that I can order. Doesn't mean you could probably not get it in a, I don't know, I'd have to look into that. So with regards to the question on heart rate spiking and prescription of propranolol and syncope, that's requires a bit more consultation. So for POTS, do you check B12? Sometimes you do because of the question of whether there's a small fiber neuropathy associated with it. And yes, I always think of that. So I don't specifically go out looking for B12 deficiencies in POTS. And we don't necessarily measure methylmalonic acid or homocysteine to determine the cellular level of B12. That's hard to do except in a research study or privately. We definitely do measure B12 if there's any suggestion of peripheral neuropathy or small fiber neuropathy. Does having a high resting heart rate speak to anything in particular? Not necessarily. It can be, unless it's into a pathologic state. High resting heart rates can occur in multiple situations. Lots of questions here. A thirst question. So, it may, why you get thirsty when you're getting a lot of adrenaline is a um, multiple things. So it can happen, is I guess what I'm saying here. Does POTS cause increased severe headaches and feeling your head wanting to explode, suboccipital and bone pain or skull, in addition to the whole body feeling your body wants to jump out of your skin? So POTS doesn't usually, well, indirectly it can cause headaches, for sure. Now, to the extent that you're experiencing no, and the other body symptoms, not necessarily. Okay, I've come to the end of the questions. Uh, the I want to thank you for coming and thank you for listening to my tired brain. And I hope that this is useful and that you've learned what you need to learn for this. Thanks again. And when you come to the dysautonomia POTS groups, I hope this will help prepare you for the medications that we're giving. Thank you, everyone. So, I'm assuming, Dr. Rick, you're maybe gone, so I'm going to end the session.